in this specialty. Also, he did more than over 3,000 cases of bariatric procedure, mashallah alayh, and is a member of Oxford International Bariatric Club. Please welcome with me Dr. Al-Hamadani.
شكرا جزيلا على هاي الدعوة والتقديم الرائع، كلش شكرا جزيلا على الدعوة. طبعا هي هاي awareness lecture, our awareness talk. لأنه هي هاي المشكلة. This problem specifically يعني not been discussed and just gradually starting to appear. So we always hear, for example, that there is a few problems with cases and outside the UK and coming to the UK with problems. But I deal with this problem literally every day, and actually this is only the tip of the iceberg. The actual problem is massive. And I'm going to discuss and I'll show you examples of that today. I'm going to show you patients who have negligent treatment. I'm going to show you patients who have nearly death experience, death of a member of the families, and also why these patients have not been treated properly, why the surgical people are trying to avoid having these problems. No disclosures. My case makes 30% revision, 70% primary surgeries. Fine. So this is the first case. This is a 46-year-old lady who had a bypass in 2019 outside the UK, and after the operation, only a few months after the operation, she dropped her weight significantly from 110 kilograms to 41 kilograms. So she lost more than 100% of her extra weight. So she became skin and bone. And the patient wasn't well. She was vomiting all the time, and she's not tolerating anything. She's vomiting every day. Whatever she eats, she's literally become emaciated. She cannot even survive. Still in the same country, she had her CT normal. She had her OGD is normal. Patient could not wait anymore. She traveled to the UK. She came to my hospital. When she arrived to my hospital, her potassium was 2. So for the non-medical person, having potassium of 2 and traveling with the potassium of 2 is a life-threatening condition. Anyway, she arrived to the hospital. And in the hospital told me, she told me that everything is normal. I think they told me that I have psychological problems. It's my psychology. We're reaching this stage. And she said, this is my original video, doctor. Can you please have a look at it and see, tell me what's the problem? So that's her original video of the operation. And it's really something very subtle, but significant. So this is trying to do the joints between the stomach and the small bowel. And you can see here, when they start to count the small bowel, they count it in this direction. They bring it from anti-clockwise, yeah? So going from the left of the patient to the right of the patient. Now, that's okay. But the problem doing it that way, when you form the joint between the small bowel and the stomach, it's going to drain to the long limb. So the drainage is going to be, whichever you eat is going to go to that limb. And this is an anti-peristaltic movement. So you're going to force the food to go from this limb back to that limb. So that's why she's vomiting. And that's why her CT scan was normal. And her OGD is normal. But again, this was a life-threatening problem. So obviously she came, it was sorted out, we revised the joint, but it was near-death experience. This is actually a bit of even worse case, but it's a bit of depressive type of talk at the beginning, but just please bear with me, it will be much better than I promise. So this is a lady who, 28-year-old lady who had her gastric bypass in Latvia. Came, lost all the weight, after a few years, become pregnant, went to the emergency department because she's feeling sick and vomiting. Yeah. And had the CT scan is normal. Okay, this must be a hyperemesis. Stay on the gynae, under the obstetricians for a few days. This is one of the classical problems that might happen with such patients because the CT scan will be normal, but they have anemia inside the tummy, which the CT scan will not show. Yeah. So unfortunately, she stayed there until she became really unwell. become septic, and then she becomes septic shock. After that, she went to theaters of emergency surgery. You know, you can imagine this is a lady who was 26 weeks pregnant, so the uterus is up to the umbilicus. So anyway, when they opened her up, more than 3 meters of the bowel was dead, unfortunately. The patient survived, but she lost her son. One of the reasons, obviously, because she had done her operation in Latvia, so there was no follow-up when she came to the UK. So no one knew what was the problem, what was the operation. Fine. Recently, the Home Office issued a warning against specific country. After 20 cases from the UK, from 2019, died in that country. Yeah? So, what is the problem? We call this one medical tourism. So what is medical tourism? Medical tourism means you travel outside your home country seeking medical treatment. طبعا the main attraction here هو cost, low-cost surgery. It usually happens in countries less developed than UK, and the main reason obviously is the long waiting times, and also the postcode lottery, we call it, because some of the regions in the UK will not provide obesity surgery, and that's one of the problems of they go outside seeking advice and help. Is it attractive? It's massively attractive. So the industry worth per year, £400 billion per year, and that's literally the economy of half of the economy of Egypt, for example. Medical tourists, in 2017, the country was about 14 to 16 million people asking for such treatment. That's 5 years ago. Yeah. Obviously, it's a massive business. It's flourishing up. Medical companies, organizations start to come up. They have certain packages there. Everything is virtual. Interestingly, I know a surgeon in Harley Street, in London, in the center of London. He provides this advice. He got no GMC registrations, but he provides such an advice. And when I start to talk to how exactly this patient in the middle of Harley Street, renting a big clinic and offering advice without GMC, the GMC said literally, well, his label is not actually a medical personnel. He's opening a business there, and he's not providing treatment for inside UK, so they cannot actually sue him. But can you imagine? It's that big the problem, and it's like an octopus arms. It's everywhere. Yeah. Obviously, the reason this package is so cheap because in these countries the wages is low. So, for example, if you have to do an operation in London, I mean, it costs the NHS about £7,000–8,000. While in this country, maybe the wages for the people is less than £1,000. And also, the medical insurance is so cheap. I'll tell you about my medical insurance. I pay £2,000 per month for medical insurance. So, can you imagine? Fine. A rough estimate of exactly how much does it cost. So in USA, the bypass about 1,800, the sleeve, sorry, 1,800, and in UK about half. But in Eastern Europe, it's a quarter of what we offer in UK. So it's really attractive. It's very attractive. And not only that, it's becoming really strong business here. Now, the insurance company in the US, the insurance company in the US have contracts with medical providers in Mexico, so they don't have to pay their patients in the US to have treatment in the US. They go to Mexico. It's much cheaper. Yeah. So it's really a very strong business here. Fine. What sort of referral we have? So we have word of mouth, online advertisements, and obviously medical companies themselves, they promote that. Usually for the British people, most likely they go to Eastern Europe. For us, where do they go? Fine. So what is the problem before surgery and what's the problems after surgery? So before the surgery, literally there's no education. So the patient goes there for 1 day or 2 days, having some consultation of different language, most likely, so you can understand how much the patient gained from these consultations. No MDT, no multidisciplinary meeting discussions, and no preoperative type of education about what you should do before and after the operation. So literally, few days after the operation, go back straight forward to the UK. International guidelines not exactly followed for weight loss surgery because there is no guidelines in that place. Obviously, these hospitals might not have as simple as intensive care units. They don't have radiology to say, for example, they have developed an abscess or collection to drain. They don't have such facilities. Because it doesn't matter, they're going to go back to UK in a few days' time anyway. So it doesn't matter. And certain countries even offer procedures, they are still in the trial stage, or not even in the trial stage. Yeah? I'm going to show that in a second. Yeah? Obviously, this country doesn't have NICE. Again, for non-doctors, the NICE is National Institute of Clinical Excellence, who's responsible to make sure that the medical supplies and the surgeries are properly regulated. So when we go to a place, for example, in the Eastern Europe, they don't have NICE. So everyone can use any type of instrument, like for example, they offer me to use some of the instrument from Chinese and from China. When you use it, you don't even accept the result of this instrument, but they use it because it's cheap again. Fine. After the operation, what could happen? Well, the patient comes to me, they don't have discharge summary, they don't have information. The patient doesn't know exactly what operation they had done. Is that bad? No follow-up. How can they provide follow-up? There's certainly no follow-up. Obviously, poor education about what type of medication they've been given after the operation, which is a crucial for weight loss surgery, the multivitamin, the supplement, the B12, the iron, the calcium. And obviously, no data to record what this country did. The most common problems of complication is when they travel to UK after literally less than a week from surgery. 6-7 hours flight, DVT-MPs are one of the most common problems. But again, putting these issues aside, that's the real problem. The problem here is that the mortality is high and the morbidity is high. And even more concerning, me as a surgeon, or all the surgeons in the UK, are not comfortable dealing with these cases. Why? Because when I operate on any patients, I have to put my own data, privately or on NHS, in a national database. I have to. So why should I put on my database a patient who came from any other country having a complication, but I have to operate on her? And it's going to be in my record, a complication in my record. Why should I do that? And you can see why the surgeons are maybe doing it on this date, on their data. They don't want this to happen. Not only that, the cost of the complication is massive. So to do a bypass in the NHS about £8,000. To do a leak after a bypass is £70,000. So why should we accept that? Why is the complication to be on me? I don't want that to be on me. But we don't have to say about this. No medical reports, the patient doesn't know anything. And when we go inside, I don't know what I'm going to see inside. It's like a surprise. Okay, let's go inside. Let's see what's the complication is. And they are not easy complications. I'll show you that in a second. They're not easy complications. They really need a very high skills. And again, why should I accept that? Fine. This is a negligent case. And I'm going to explain why it's a negligent case. So this is a lady who's a 36-year-old lady. Sleeve gastrectomy outside UK. After 3 days, she left that hospital in that country. And after 3 days, so not even recovered yet. She came vomiting in the plane. So she was vomiting on the airplane. Came to the UK, Heathrow, straight to the hospital. Ambulance, I don't know if she came with me. On arrival to the hospital, you can see her markers, so temperature 38, water count 17, CRP 300, severe abdominal pain, quick CT scan, which I didn't even bother. I just, let's take it to theatre, really. And that's what we found in theatres, yeah? So after we cleared everything out, this is after an hour of me clearing everything out, what I found this big lump. That one. This big lump, compressing the liver. It's full of secretions, like this big, so about a liter there. I obviously aspirate part of it to make it so you can appreciate it. Obviously, the more I try to separate from surrounding structures, and then you can see it's a dusky color. So it's a black, infected part of the stomach which was left. Now, as you can see, it's stuck to the spleen. So I have to just rip it from the spleen, just extract it from the spleen. You know the spleen. Spleen, if you touch it, you bleed. This is a septic, high temperature fused with the spleen. So actually, it's anyway. the surgeon did, well, this is the stomach. She had the sleeve, the surgeon did the sleeve, and he left the stomach. عاف السtomach وطلع. بس خلينا نفتهم, let us understand why he left the stomach. Not because he's a bad surgeon, he's an excellent surgeon. That's the whole point. The surgeon, when you go there, they are very experienced. They're a bit more experienced than me. It doesn't matter. But the problem is, he's having 12 cases to do on that day. Yes? On one day. I mean, I do my whole day 3 cases. He do 12 cases that day. So he opened 3 theaters. I know him. I know the chap. I know his skills. He's very experienced. So he opened 3 theaters. So he jumped from this theater after half an hour, he got to that while his team preparing the other one, and then he got to the other one. So while he got to the 3rd case, the first people in the first theater are closing. And obviously they're very busy. They forget the stomach, so they're going to come to me anyway. So, this is a negligent case. Now, this is a case of poor results. So, a 48-year-old gentleman had laparoscopic gastric plication. We don't do this operation anyway. It's still on, it might be done in different countries, but a new case is not yet approved. And it's not past the trial stages, so it's not even the trial stages. It doesn't mean it's a bad operation, but that's the stage of the operation at the moment, yeah. So he had the operation six years ago in the Eastern Europe. He did not lose any weight. And then now, he comes to the NHS, and the NHS has to fund a new surgery. Now, the problem with this, obviously came from conversion. His BMI is the same, it's 46, hasn't dropped any kilograms. So that's the actual operation. So what would they do with this operation? They instead of cutting the stomach and the sleeve, what they do here, they evaginate. They close the sutures, close the abdominal wall with sutures, close the stomach wall with sutures. Yeah. Now the problem here. Yes, working. Right. So the problem here is when you revise such an operation, the problem is not the operation itself. The primary procedure is always easy to do. The problem is when you go back and try to solve it out. Now, you can see the stomach size is exactly the same. So exactly the same stomach. But the problem here is if you try to staple across the stomach, you will end with a leak. Why? Because there's these sutures actually holding the stomach together. So you have to go all the way around, from the beginning to the end. Take all these sutures away, because if you leave one suture, the patient will die. Will having a leak and will die. And that's again on my theatre list. Now why should I accept that as a surgeon? Why not? Doesn't matter. So as you can see, you have to take all the sutures meticulously, all little sutures, microscopic sutures, because with time they give way, and that's why the patient put weight on. But anyway, it doesn't matter now. The patient now on my theatre list, I have to solve them out. So I have to take all these, put the stomach back to normal, cut the stomach away, and then do the bypass. So this is an example of a poor results. Now, this is similar to the first case I mentioned, the lady with internal hernia. And just give you a taste why such a patient won't be taken easily by surgeons in the UK. ليش الجراحين بالUK ما يريدون هالكيسات تجيبهم؟ هذا خوش مثال. I think it's a good. So هاي البيشنت هي 33 عمرها 33 years. 33 weeks pregnant, يعني أكبر pregnancy age أكبر من أول واحدة شفناها. 7 years بعد البايباس. Severe abdominal pain in Birmingham. وقت 4 أيام 5 أيام في Birmingham. والsurgeons in Birmingham, طبعا Birmingham is a big center مثل ما كنا نعرف. There are at least 3 or 4 large bariatric centers there. So there's no excuse not to be treated in Birmingham. But the patient has 4 days in that hospital. In Central Hospital in Birmingham, they have bariatric surgeons. Anyway, still in pain. She heard about us somehow. I don't know how she heard about us from London. So she took a taxi. She discharged against عافت المستشفى عافتهم. وركبت التاكسي هي البيشنت عفوا زوجها أخذها بالتاكسي ونزلها من برمنغهام She passed maybe 10 or 11 hospitals on the way from Birmingham until she reached my hospital, just because she had a bus to have her operation. فخلي نشوف ليش السيرجنز ما يقدرون take such a case؟ شنو المشكلة؟ يعني ما إذا. Rafa, I'm not going to see your coffee time.
You have 5 minutes.
Yeah, that should be fine. المشكلة when you put inside, this is a massive uterus. The uterus up to there, this is higher than the first case. فالمشكلة البowel is underneath the uterus. So in order to do anything with the bowel, you have to let the patient laparoscopically standing up like this. Yeah? On the table, from a flat, you have to stand up to disengage على مود نوخر اليوترس من البowel so you can deal with the bowel. Otherwise, how can you reach the bowel? You cannot reach it physically. والمشكلة من طبعا هي عندنا internal hernia. أشوفكم internal hernia second. المشكلة إنه when you try to, this is with the nearly 90 degrees bed out. When you try to pull the bowel, you can see, you can easily perforate the bowel. Have a look. So I'm trying here to find the ileocecal. This is the cecum. Look, I'm pulling it really hard. دا أجرب بكل قوة على مود بس طبعا while the patient is standing up, just to disengage this bowel from the uterus. Yeah. بس بعد الحمد لله جت ايد مشت. بدنا نجر الباول. وكان نشوف this is the hernias coming up. Hernia يعني again for non-medical people is a hole through which bowel can go in and out. So this bowel is inside and is stuck inside, and the blood supply of this bowel is cutting off. So we have to take it out. There's no other way. Yeah. But now you can see the bowel is reduced. Yeah. And that's the hole. You can see it's a very small hole. About 2 meters of the small bowel was there. And then this is the closed hole now. المشكلة بهالعملية specifically أنه if you try to open her up, طبعا for the surgeon who doesn't have laparoscopics, or حتى if you are anxious about the bowel injury, which is fine, with any surgeon it's fine, you cannot close her back because the uterus is this big. You won't be able to close her back. Yeah. So you're literally risking patient's death and patient's death and the baby's death. So that's why people doesn't want, and surgeons really don't تعملون each case out there. It's just too much for the surgeon. Anyway, the patient was very thankful. Hernia was reduced, went home, and after 3 months from the operation, she sent me a thank you letter with this. Fine. Great. Fine. Then, a few things to say. المشكلة بالمedical tourism, it's fine, but there is no international guidelines about medical tourism. There won't be any, that's the whole point. There won't be any international guidelines for medical tourism. ليش؟ لأنه £4 billion a year. Why should we change anything? Why should countries like Turkey, I'm going to mention Turkey because the Turkey was in this warrant from the Foreign Office. Because Turkey having billions, not millions, billions of pounds, why should they change their policy so they have less income coming to them? There won't be any changes. Obviously, from our point of view, there's no continuity of care, no patient medical notes, no patient-informed choices because there's because of the language barriers and everything else. I'm going to take this quote from the SMBI, which is the American Association. They said that going outside the country, any own country, to have a surgery is fine, but it's not the cost or the quality of the surgeons. They're good quality surgeons. The problem is not their skills. The actual problem is this weight loss surgery. The main parameters is to let the patient educate before surgery and make sure you have a very strong follow-up process after the surgery to make the procedure work. That's the point. Not because of the skill of the surgeons. طبعا thanks a lot. أنا أخذكم هواية. the patient give us permission to give us their...
Thanks, Dr. Ali, for this nice presentation. I have a question about the second case. That lady, pregnant lady, 26 weeks pregnancy, she came directly as an acute abdomen without any previous sign of symptoms. And at the time of operation, it was before the
When I
pregnancy.
was involved in this case's investigations because they called me as an external witness, external expert. أكو عدة جوانب فيها. طبعا I totally agree that her management wasn't optimal, and in this hospital they could phone